Thank you to Medicontur and Crystal Vision for having me here. We might get the slides started, please. My name is Dr. Alison Chiu. I'm from Sydney, Australia. I'm a cataract and refractive surgeon. So I want to talk to you about incorporating toric IOLs for the best refractive outcomes. And just imparting some pearls and sharing some wisdom. So I don't know if anybody in this room knows this group of people, but this is from an American sitcom called The Golden Girls. And this is a show that ran on TV around 20 or 30 years ago. And this is a group of 50 and 60-year-old women. And the world really is changing because this is what 50 and 60-year-old women look like now, as well as this. And moreover, that generation called the baby boomers that are in retirement now are doing very different things to what they were doing in their retirement 30 years ago. So we have to meet the challenge and meet the expectations of these patients, where the expectations really are a lot higher and they're living much more active lives. So let's talk about astigmatism correction. So I want to cover in this presentation why should we use a toric IOL, and following that, how best to use toric IOLs. So I'll be covering making the decision to use a toric, marking the target axis, how to ensure your toric IOL stays where it should, and the IOL design and how it impacts toric success. So this is Dr. Holland's data and shows the prevalence of corneal astigmatism prior to cataract surgery. And this data is a little bit old, but it does show that there is a significant amount of corneal astigmatism. And we don't care so much about the refractive astigmatism because, of course, we're taking the lens out. So we just want to neutralize the corneal astigmatism because the lens is coming out anyway, whatever that may contribute. And there is a visual impact of astigmatism where it does create spread of a point spread function of a monofocal IOL when there's residual astigmatism, and this creates blur. So as Munwai alluded to, we are the toric capital of the world. And again, also this data is a few years old, but when it was canvassed, the percentage of toric use in Australia was 60%, which was far ahead of any other country in the world. So the next question is, why are we using so many toric IOLs? It's not just related to our insurance systems and so on. Are we crazy? So then it caused me to have a look at my data. And at the time I put this talk together, I looked just at the previous month, which was 107 cases. And I had only one non-toric lens that I had used. And this was in a series of only monofocal lenses. So this was not looking at presbyopia correction. So then I thought, am I completely crazy? So that forced me then to go and audit my data, because I thought, if I'm using all these toric lenses, am I at least getting better outcomes? And I was hugely relieved to see that my results within plus minus 0.5 of a diopter were 91% and above the international benchmark standards. So thank goodness. I would say my toric use does fluctuate. That month was a high toric use month, but it's never below 70%, so still well ahead. So we know it's a good idea to use toric IOLs because it results in better refractive outcomes, but how do we use them? So Munwai also alluded to taking the ocular surface seriously, and I really can't underestimate it when you're looking for the best refractive outcomes. So if you don't take any notice of the ocular surface, it will come back to bite you, both with your refractive outcomes and with complaints from your patient post-operatively. So just be very aggressive treating the ocular surface pre-operatively, whether you're looking at using a premium type lens or not. And I just want to demonstrate, usually when I'm looking at biometry, I'll go first to, I use an IOL Master 700. I always flip to this analyze page first. And you can see the keratometry here, the dots. They're all smudged, they're not even, they're all over the place. So I know that this is not a good biometry, and I can tell that this patient has dry eyes before I even examine the patient at the slit lamp. So based on this biometry, a lens that would be recommended by the biometry is a 1.5 diopter on the TK. So I do use the TK for the astigmatism correction magnitude and the axis. But sending this patient away for some dry eye treatment, and usually this consists of just a preservative-free lubricant 4 times a day for a week or 2. Plus, if there's punctate epitheliopathy, that tells me there's an inflammatory component, so I like to add FML. I don't know if you have that brand of drop here, but it's a weak topical steroid, fluoromethylone, 3 times a day for 1 to 2 weeks. Repeat the biometry. So you can see that those keratometry marks are a lot better in this repeat scan, and the Ks do change. And based on the biometry, a 1 diopter astigmatism correcting lens is now recommended. So it will impact your outcomes if you're not getting good measurements preoperatively. Next is the preoperative axis marking. Then we have to place the IOL to the correct axis, and part of that in ensuring that the IOL stays in the position that you put it in is not just the design of the IOL, but also removing all the viscoelastic from behind the lens. And I talked about the design in terms of the stability. So can we have some audio here? This is just one of my operating lists last week. I'm in the preoperative area. I've actually taught my anaesthetist to do this, but I did it for the video. And I'm instilling a drop of local anesthetic because I'm going to mark this patient's eye in anticipation of his surgery. So all I do is I use a sterile ink mark. I get him to look straight ahead into the distance, and I'm just putting his chin down so I get better access to the palpebral fissure. He's blinked, it's not a problem. I replace that mark, and all I do is place a mark at 0 and 180 degrees. Then you can see I have a very fancy looking spirit level on my iPhone, and I'm checking the marks at 0 and 180 and just adjusting if my mark is a little bit off. So that's an app called Toric Cam, which was developed by our own Graham Barrett, and he's published that marking the axis preoperatively in conjunction with using the Toric Cam app, which is free on the App Store, does increase the reliability of your preoperative axis marking. So I also, that's just another patient, we'll slip past that. So when I sit down at the microscope, the first thing I do at the beginning of the case is there are some very faint marks that I made in the anaesthetic bay here at 0 and 180, and that video will loop so you can see that. And I use a Callisto alignment system. I've also used the Alcon Verion alignment system as well. So I don't like to wait until the end of the case, because if there's some extra chemosis or heme during the case, then it can make the digital alignment system difficult to detect the axis. So at the very beginning of the case, I'll mark the implantation axis, and my pre-operative marks are just to double check that the yellow line, the 0 and 180, is aligning at or almost at my preoperative marks, because sometimes these digital alignment systems do funny things and they don't detect the correct limbal blood vessels. And sometimes you cannot get an alignment down the digital marking, and you have to revert to a manual marking system. So getting out either a Mendez gauge or pulling these marks in digitally on the system. So that's just belts and braces, extra things to do to make sure that I don't miss the marks, that they're the most accurate marks I can put on. So then the lens goes in, I rotate this lens to the target axis. In this case, it's 88 degrees. And then I remove the viscoelastic. So I use a coaxial IA. If you use a bimanual IA, it probably is a bit easier. You can tilt the lens a little bit more easily to get underneath the lens. I don't always go underneath the lens, but sometimes in some cases you can get a little clue, and there's a little posterior capsule fold there, and it's almost at 90 degrees to my axis, and it can be in any degree. And that's an indication that all the viscoelastic's out. So it is important to make sure you get all of it out. And then post-operatively on day 1, often my patients are still dilated, but if their vision's not good, especially in premium lens surgery, then I will dilate the patient on day 1. I usually don't need to. I can usually see where the mark is. So it's easier to see on the slit lamp than in a photograph. Obviously, there are 2 marking points, but I can quickly cross-reference the implantation axis at the, with what I see at the slit lamp to ensure that the IOL on day 1 is in the correct position. Now, I want to now talk about the design of the Medicontur IOLs, because they do have a double C-loop haptic, and I think that that is really important with the rotational stability of toric IOLs. And I find that if there's a problem with the alignment, it's not because the lens shifted, it's because it was not put in at the right position. So the biflex lenses across the platform, so the monofocal torics, the monofocal, also the non-torics, but the Liberty, the Elon, they all have the same platform where there's 132, around 133 degrees of contact with of the haptic with the capsular bag. And if we compare this to other lens designs, it is the lens design that has the maximal contact, and this is part of the rotational stability of this platform. So really having a rotationally stable IOL when you're using toric IOLs, and as we all know in this room, I use a lot, it is really important in terms of the final outcome for the patients. We want happy patients. Happy patients make happy surgeons. And there have been studies that have looked at the rotational stability of these biflex Medicontur lenses. So the monofocal comes in a hydrophilic and a hydrophobic version. Most hydrophobic versions across all companies can correct up to about 6 diopters of astigmatism. But it's good to have familiarity with this platform, because when you do deal with those unusual eyes that have higher astigmatism, then we can get custom-made higher sills of up to 24, which is, I think, the highest available on the market. So it's just good to be familiar with a platform when it comes to dealing with more unusual eyes that have really high astigmatism. So your stable keratoconics, your marginal pellucid degeneration, post-PK patients, and so on. And I just want to finish off now, so it's a fairly brief talk with my pearls for astigmatism correction. So I am not afraid at all to flip the cylinder, so to overcorrect it. I like to implant the IOL that leaves the least amount of residual sil, and I think that this is probably why my toric use is so high, because I'm implanting, I don't have a cutoff of, 1 diopter of astigmatism or 0.75, or is it with the rule or is it against the rule, because the thresholds will be different for astigmatism that's with or against the rule. And if the IOL master is showing me the amount of astigmatism to get to emetropia is closer to 1, even if the corneal astigmatism is as low as 0.2, I will be putting in a toric to get the least residual sil. So flipping the sil, it's not problematic like flipping the sil in spectacles, because you don't get that prismatic distortion. And it's not problematic like flipping spherical aberrations. So we do have some lenses available on the market that are negatively spherically aberrated, whereas the Medicontur range is neutral, so we're not ever going to flip the spherical aberration, so we can easily flip the seal without having any concerns. So we know that fully correcting astigmatism is super important with presbyopia correcting lenses, particularly the multifocals, the diffractive lenses. We also know that extended depth of focus lenses can be a little bit more forgiving, but it is ideal to have the best refractive outcome, and also with monofocal lenses. So I noticed at the beginning with the slider that most people are using monofocal lenses, so I would encourage you to think about being very aggressive with your dry eye management firstly, preoperatively. You'll run into less problems postoperatively, and also very aggressive astigmatism correction for the best visual outcomes for your patients. Do we have any questions?
I have a question. I think you showed how you actually calculate for your toric corrections, your astigmatic correction with, you use the TK, did you say?
Yes, so...
Is that part of the IOL Master 700, or do you have to use the website?
No, I have it. It's an added software on the IOL Master 700. Yep. So the IOL Master 700 comes basic, and there are two add-ons. One is central topography. I have it, but I use a topographer on all my pentacam on all my patients anyway. And I think if you're heading down the more refractive space, really you should use a topographer, or at least have Central K, and then TK is also a software add-on. So for my results, I appreciate I do something a little bit different, and I take the K to get the sphere, and I take the TK to get the astigmatic correction in terms of magnitude and axis. And I appreciate some people look at me quizzically and go, why are you complicating it? And I'm complicating it because my outcomes are excellent. So I'm looking forward to hearing from you your Elon outcomes, but when I look at my Elon outcomes, I have 100% of eyes within plus minus 0.5 diopters. So that's just my personal pathway that I've tweaked and developed over time. So I use the K for the sphere and the TK for the seal.
Right.
Yeah.
So I think for those of us here who may not be sure what you're referring to, so perhaps you elaborate a bit. What's the TK, and what are actually you talking about, in case not everyone's familiar with Barrett?
So the TK, my apologies, the TK is the total keratometry. It takes into account the posterior corneal astigmatism. So, and it's something that Graham Barrett, brought about, and in conjunction with Zeiss, it's available on the IOL Master 700. So astigmatism is not just about the anterior corneal surface. The posterior corneal surface also has an impact on the overall corneal astigmatic effect. And that's what we're trying to neutralize when we put in a lens.
Yeah.
So I really do see, once we took on TK, an improvement in our outcomes. But what I would say as a little pearl, the reason why I don't take TK as a sphere and a seal and just read it off there and go click, yeah, that's it, is because TK in my hands, I believe, does produce slightly more hyperopic outcomes. And nobody's really very happy when they're left a bit hyperopic.
So I think the total keratometry is not available in all machines, unfortunately. I think Zeiss, the IOL Master 700 does it. I think perhaps there's some other machines that do it. Now, I don't have the IOL Master 700, so that's why I do not have 100% within plus minus 0.5, I think, so I have to get that, do I? But I think what I do, I use the integrated K. So I use Barrett's integrated K that is on the website. So what the integrated K is, you need at least 2, but preferably 3 different machines to enter K readings into that website of calculation, and it gives you a median. So that sort of, I think Graham Barrett has come up with a way of, trying to optimize your calculations by using more than one set of K readings. And because I do not have something that measures total keratometry, that's what I do. And admittedly, I'll show you tomorrow, my Elon results are not anywhere close to 100% within half a diopter. But perhaps I should get the IOL Master 700.
Because we are the toric capital of the
Yeah,
world, prior
yeah.
to Graham Barrett implementing that alongside Zeiss into the IOL Master 700, another Australian ophthalmologist by the name of Michael Goggin formulated an adjustment which is population-based,
Right.
so rather than individual TK measurements. But if you Google that, I think there is a Goggin formula for you to adjust for population-based methods rather than individual measurement.
Okay, I think what to take away from that is, you know, it's become very complicated now, I think, the discussion, because we're going to talk about
It has,
doing more than
yes.
1K reading. You got total K, you got integrated K. But I think what we're trying to highlight is that if you want to get very good outcomes, I think one of the things I think I mentioned, and Alison has already done it in practice, and before she delivered this talk, she audited her own outcomes. Why? Because she wanted to see how she was doing. And that's why we are doing all this. So to fine-tune all that little, you know, 1%, 2%, 5% perhaps, and you're actually trying to deliver that little bit more for the patients. And I think it is worth it, because ultimately 91% and 85% is difference of 6%. You might think 85% is still very good, but 91% is better. So I think if you at least have a optical biometer with a set of Ks, that's good enough. I think most of us will also have probably perhaps an autokeratometer. I think if you have more than one set of Ks whilst you're doing toric IOL calculation, it's probably more accurate than just having just one machine, unless of course you have the total keratometry.
Yeah, I'm sure everybody here is doing at least 80% of their work really well. But I guess we're here to talk about how can we can improve ourselves every day. We can
Yeah.
always do better, and that results in a better outcome for our patients. So we're here to, find the smaller gains.
Yes, that's
Because
right.
the technology that we have available today, actually, even just in phaco emulsification, is incredible, right?
Yes.
Come a long way.
I think, like you said, the dry eye management itself will give you that extra 5%, perhaps. Yeah,
I think so,
and that's
yeah.
important. Okay, so there's a question here. I think Medicontur have their own calculator as well, isn't it, for the toric calculator and all that. So if there's a discrepancy, perhaps, do you use the Medicontur calculator for your...
I used to use the calculator, actually.
Yeah.
Is that the optimizer? Prior to,
Yeah.
routinely using the IOL Master 700.
So the question here was, if you have the Medicontur calculator and perhaps you use the Barrett's calculator as well, and there's a discrepancy for the Toric IOL, which one do you use?
Well, I'm Australian, so I'll always go for Barrett, but we can have a debate about that. I don't have any data to back that up, so...
Yeah, I think I exclusively use the Barrett suite, so whether it be for spherical or toric calculation, I think perhaps I am biased as well, because I've attended a lot of Graham Barrett's talks, and I've used his formulas for a long time, and I think you can't go far wrong with that. So even with the different lenses like Medicontur or perhaps even Alcon or all the other platforms have their own calculators, and they have incorporated Graham's algorithm into their own calculators as well, but I still use the Barrett calculator. So I think you won't go wrong with that. And it's free. It's available to you on the APA CRS website. And I think that's the website where Graham will tend to update more frequently, because I think it's also available on the ASCRS website, but the APA CRS website is the one that I tend to use anyway.
Yeah, I think the APA CRS website's great. It's got
Yeah.
Graham's stuff on there.
That's right.
And while I might talk about using KTK, there's only sometimes discordance between the astigmatism correction, in using TK compared to K. So I think if at least you're thinking about using a toric and aiming to use a lens that leaves the least residual astigmatism, if you're using just one method, just using the K, then you're still winning. I think you're still winning.
Yeah. Are there any more questions out there about anything? Oh, yeah, Javi.
Yeah, nice talk, Alison. My question is, for patients, for example, with keratoconus, are you doing anything different with your measurements?
Not so much with the measurements. I am with the formulae, so I will tend to run a Kane formula, because Kane is another Australian ophthalmologist that's developed some formulae. His formulae are in the ESCRS calculator, but he has a Kane keratoconic formula. What I do with the keratoconics is, even though I spoke before, we don't care about the refractive astigmatism. We care about the keratometric astigmatism. I do take actually the refractive astigmatism into account more with the keratoconics, because the cornea is very steep. Often the steepening is inferior, as we know. The cornea is weird, and often I find the keratometry will overestimate. So if you go order a special lens of +10, +12 diopters of astigmatism correction, you may be overcorrecting it. So tomorrow I'll talk about the secondary sulcus add-on IOL, where there are two approaches. You could do a primary monofocal in the bag, and then just based on the refractive astigmatism post-operatively correct the astigmatism with a secondary lens. But what I tend to do, that's a second procedure for the patient, that's additional cost. What I tend to do is look at the refractive sill, see if the axis lines up with the keratometric corneal sill, and do a calculation in my head where there is a conversion between spectacle lens power for astigmatism correction and IOL, or even there's a conversion of 1.3 between spectacle and corneal. So I just calculate it to make sure, am I going to be overcorrecting if I use the IOL master? Often I am. So I then will take more an adjustment from the spectacle or refractive sill, just to make sure, because I found over the time that those, if I choose just on the lens, whatever got spat out by the biometer, it does tend to overcorrect it. Yeah, it has trouble measuring. What do you do, Harvey? Do you measure anything differently with the keratoconics?
I just use different topographers and kind of average things out.
Yeah.
We have been burned with we have been burned with overcorrection a
Yeah.
few times. So
Yeah.
thanks for your tips. So I'll start using that technique, because what we do now is to just average several measurement devices and use that average.
Yeah, I think if you looked at the pentacam and you took more of the central K, so you can look at the 1 or 2 millimeter ring, it probably might be a little bit more accurate than that larger area of K, because they're not so steep centrally usually, and that's why we're getting overcorrections with the biometer. Yeah.
I think we have one last question before we actually, head off to do a little bit more, something more exciting perhaps. Something about the
Why?
Elon.
This is very exciting. What are you talking about?
Okay, no, for the Elon lens, I think we have population of high myopes, which are present, I think, in Taiwan and also in many parts of Asia. So if you have a long eyeball, 27, 28 millimeters, what would you aim for if you're using an Elon lens?
Look, I don't have the data on that, but my gut feeling is to aim for a little bit of myopia, because if they end up a little bit myopic, they're going to be okay with that. If you end up erring on the side of hyperopia, yeah, you've got the range of focus of the lens, which has some forgiveness to it. But if you're leading them into a hyperopic outcome, you're sort of eating up that range of focus for them. Yeah.
Yeah, I agree.
What
I
do you
think
do, Mun? Well, you deal
same.
with more high myopes than
Yeah, I
do.
think with the high myopes, I also had this discussion with Dr. Lin earlier, and we tend to try to err on the side of myopia. I think it makes sense because these high myopes with it -6, -7, 10 diopters. So if you get them right within a diopter, maybe it could be -1 even, then you'll find that, they might be 6'9", maybe 6'12" for distance.
And they think that's great,
That's
actually.
great. Yeah, 6'12" for distance is great compared to what they had without glasses. And you get there near. So that's very important to them.
Yeah.
So I find that, we tend to go for more myopia. So in such a case, I would go for at least a half, 3/4 of diopter, maybe even a diopter of myopia. I think that's fine.
Yeah, the other piece is that if you are doing laser vision correction, then it's just going to be a lot easier to correct a small amount of myopia
Rather than
than to be doing a hyperopic correction. Yeah.